Okay. Hey, welcome to our 10th Showcase Tuesday. Tonight covering maternal and child health, one of Rotary's 7 areas of focus. Rotary supports training, education, medical projects for maternal and child health. Through these initiatives, Rotary makes healthcare available to mothers and children so they can live longer and grow stronger. Rotary achieves these goals through partnerships with the Rotary Action Group for Reproductive, Maternal and Child Health, WHO, and medical professionals and volunteers. Tonight, we will record this session. Please mute yourself during the presentations. You may unmute yourself and ask questions after each speaker presents. If you don't want to be heard, please enter your questions in the chat box. Marlene Heller of our Learning Committee will pose questions from the chat box to our speakers. I have some questions. Why are there about 6 million preventable deaths of infants and children each year? How can we help reduce the 303,000 annual mother deaths at childbirth? Why are children deprived of mother's milk? Infants, especially premature infants. Tonight, we will hear about how the Rotary Action Group for Reproductive, Maternal, and Child Health saves women's lives, and how Mother's Milk Bank saves infants' lives. Okay. Our first speaker is Dr. John Townsend, PhD, Chair of the Rotary Action Group for Reproductive, Maternal, and Child Health, and Chair of the Population Council's Ethical Review Board. He received undergraduate degrees from Marquette University and his doctorate in social psychology with supporting studies in public affairs and educational psychology from the University of Minnesota. John lives in Washington, D.C., but has lived and worked in 35 countries around the world. He began with the Population Council in 1984. Before that, he worked as a social scientist with the Pan American Health Organization. He is chair of the Institutional Review Board of the International Center for Research on Women. He works to improve the coverage, quality, and sustainability of reproductive health service delivery systems. John is a member of the Rotary Club of Capitol Hill. Our second presenter is Dr. Pallavi Deshpande. She's the lab director and clinical microbiologist at Deshpande Diagnostics, chief operating officer at Vidal Institute of Child Health and Specialty Center, and technical director of the molecular lab at NMR Diagnostics. She received her MD microbiology from Christian Medical College, MBA from healthcare administration from Manipal University. She holds a diplomat membership from the Royal College of Pathologists, United Kingdom. In her free time, Dr. Deshpande serves as the president of the Rotary Club of Seven Hills in Darwin, India. She's helped with many service projects, including 2 global grant projects, one of which we'll hear about tonight. Her husband and father-in-law are both doctors and Rotarians. Dr. Deshpande has a son, a daughter, and a passion for service. Let's begin with John.
Thank you very much, Bob, for the great introduction, and to all the participants here. Good evening, colleagues and friends of Rotary around the world. My name is John Townsend. I'm the chair of the Rotary Action Group for Reproductive, Maternal, and Child Health. As we reflect on the rich, inspiring stories of Rotary's impact globally, I want to draw our attention this evening to the partnerships that we need to foster to deliver health and reproductive justice for women and their children around the world. Despite a nearly 50% drop, let me put on the screen here. Despite a nearly 50% drop in maternal deaths globally in the past decade, from over 300 women dying per 100,000 live births to around 150 per 100,000 births globally, there are still many countries in sub-Saharan Africa and South Asia where the death rates remain unacceptably high. About 2/3 of the 800 women who die daily in childbirth or shortly thereafter, they occur in sub-Saharan Africa and about 1/5 in South Asia. For example, a woman in Nigeria is 200 times more likely to die in pregnancy or childbirth than a woman in Europe. Even in the United States, with the highest per capita expenditures on health, about 20 women die per 100,000 live births, which is more than most countries in Europe. Moreover, the maternal death rate for women of color in the United States is nearly twice the national average. Tragically, the same is true for neonatal deaths, which is highly associated with maternal deaths. In 2006, Professor Mahmoud Fatala from WHO and the president of the International Federation of OBGYN said, "Women are still dying because societies have yet to make the decision that their lives are worth saving." The image on this slide speaks to this quotation, and it shows a too often typical recovery room in rural sub-Saharan Africa. It bears testimony to the challenges facing maternity care at the lowest level health facilities in much of the sub-Saharan Africa and South Asia. If we're to change society's responses, we need actually a better understanding of the costs of inaction, the basis for engagement that bring us together, and the building blocks of health systems requiring significant investments. This is a slide about the Sustainable Development Goals, which provide a blueprint for achieving a sustainable future. It was approved by the UN General Assembly in 2015, and admittedly, it's owned by communities around the world. The focus on MCH that relates to maternal deaths and child deaths can be found in 4 Sustainable Development Goals. 3, ensuring health and promoting well-being. Sustainable Development Goal 5, ensuring gender equality. Number 10, which is reducing income equality across and within countries. And finally, strengthening partnerships for achieving these goals. In order to really make progress on these Sustainable Development Goals, we have to need to understand the costs of failure to act responsibly and ethically. I'd like to mention just 3. First, the continued tragedy of preventable deaths and disability of women and children. We have to understand that for every woman who dies, 20 are seriously affected with complications that require further care by often underfunded health systems. Women's suffering continues and their infants suffer as well. Second, due to the cost of healthcare and consequences of income loss, many families fall into poverty during these episodes of maternal death and disability, making their progress towards health and development more challenging and often impossible. Finally, in the longer term, the economic, social, and political opportunities for women's leadership in their communities are delayed or lost while they seek to give life. So it's clear that in terms of our response, small projects that merely address specific elements of maternity care are simply not enough. Public health impact is only possible and persistent monitoring of the building blocks of health systems to ensure that the promised benefits are realized. I want to give a brief overview of kind of the objectives and purposes of the Rotary Action Group. We seek to enhance human well-being and dignity aligned with the Sustainable Development Goals, improve women's and child health and environment, ultimately seek a sustainable balance between population and environment as these issues clearly interact, and finally be a resource for districts and clubs in the MCH area of focus. We work around the world. We were founded in 1995 as a RAG for population development, but wanted to focus more clearly on those elements that affected families and individuals in the poorest communities. It supports over 13,000 members, including Rotarians, Rotaractors, country sections, and clubs We include cadre and fellowship members, and we have a board of directors from around the world, many in Asia who I'm sure weren't as motivated to get up at 4 a.m. as our colleague in Pune is. The work streams that we operate are expression of how Rotarians could contribute. We work in many places, and I'll highlight probably Nigeria as our best example, improving birthing the quality services and family planning services, build provider capacity for quality maternal services. We do that in India and Uganda, enhancing women's status and well-being through Saheli centers across South Asia, supporting comprehensive sex education and skills of youth in many countries. And we work with colleagues at the World Bank and other development institutions for promoting education among youth for development. And we're just forming a new effort called the Technical Expert Networking Alliance, TENA, which seeks to bring together a series of people from around the world, including those as donors and governments and professional organizations, to work with Rotary clubs to make a difference locally. We can talk about that later. Our history of cooperation is one I think that I'd like to mention, both with WHO, UNICEF, and others, as well as professional bodies such as International Federation of OBGYNs and the Association of Midwives and Nurses. We have a common commitment to sustainable development goals related to improving health, reducing inequalities, and promise of partnerships. We have a history of working together on global polio eradication, with efforts ranging from financing to ensuring the last mile vaccination coverage and surveillance. So we have a history of cooperation and trust. We both call for the scale up of high impact practices. So doing something that really small over the long term is probably insufficient to make progress on the sustainable development goals. We've been working for over 25 years in Nigeria on maternal death reviews, quality delivery, and contraceptive services in cooperation with the government and civil society partners in the National Family Project in Nigeria. As duty bearers, both organizations, the UN and Rotary, pursue reproductive justice by responding to the voices of communities and empowering women. So the stories of women and their families across the globe demand our commitment to ensure that women's lives are indeed saving. Our call to action is roughly as follows. We want to make investments in health system building blocks, including supply chains, human resources, infrastructure, and information. We need to support gender equality to ensure that women's health and empowerment are given a priority. We need to facilitate the scale up of evidence-based high impact practices, which make sure that the evidence for doing what we're doing leads to impact and sustainability. And we want to ensure we're engaging communities for their voice and meaningful contribution, as well as equitable access to benefits. Ensuring partnerships for critical stakeholders is critical for sustainable development. It's time for our societies to say with one voice that enough is enough. We will not accept as inevitable the deaths of our mothers, spouses, and daughters around the world. Their lives and those of their children are worth saving and worth investing in. Yet we can only eliminate those most preventable of deaths and the huge losses to families and countries if we pursue reproductive justice together. So let's commit to these partnerships to ensure that women's lives are at last worth saving. I want to just kind of finish by there are kind of three take-home messages. One, we want to make sure that we deal with mothers and children as a dyad and not always separately. We want to follow up women who have given birth and their children in the community and give special attention to those with special needs. And I think that's the focus of Dr. Deshpande's presentation. And I want to make sure that we're empowering families and communities to make investments in health that we know that will contribute to their overall development. This week, the WHO came out with new guidelines for postnatal care, and I think you will find that Dr. Deshpande's comments reflect the state of the art and what is best for women and their infants in need. Thank you very much.
Thank you, Dr. Townsend. Does anyone have any questions they'd like to ask? We have a great resource with us right now online. So if anyone wants to ask John a question, this is the time.
Yes, Sanjay. I think you're on mute.
Yes, I wanted to ask if the RAG helps clubs doing global grants in any way, expertise or even funding?
Yes, we do. And we do that primarily in those places where maternal and neonatal deaths are highest. So India, Nigeria, Uganda, and we'll be doing more, I think, in Kenya. And in India, I mean, there are places, as we know, where states in the South pretty much look like Canada in terms of health outcomes, but there are places in India that have real challenges, such as Uttar Pradesh and other states in the north. And so we like to work together with districts and clubs on projects that make sense. We don't compete with the cadre or the cadre, as some people call it. We work with them, and we hope to find the significant synergies between the skills of the cadre, but some of our focus is a little broader. We like to bring in the OBGYN societies and others that sometimes Rotary groups fail to do. And there's a real value there. Good question.
Anyone else? Marlene, are there any questions in the chat box? You're muted.
I have a couple of questions here for you.
Right.
John, what is reproductive justice?
That's a great question. Reproductive justice is a concept that hasn't been around a long time, but it's really the right to plan a family or not to have a family as part of the discussion of economic and social empowerment. It means that women who need access to care can get access to care. And it isn't just because they don't have the money or they are not close to a facility, but rather sometimes social and economic factors in their background limit their ability to use those services effectively. Even in the United States, there's some work been done by Columbia University in New York about the lack of respect during birthing. And there's a new movement called Respectful Maternity, which understands that women's right to information, to make choices with the people that she feels important. It could be her spouse, it could be a family member, it could be a doula. So reproductive justice essentially tries to make sure that she has the decision-making ability and people respect that, and all women should have access to that same respect and quality.
So that leads me to another question. You had mentioned that one of the goals was to enhance women's status. How do you enhance a woman's status around the world?
There are lots of ways of doing it, but it usually begins with education. So girls' education is something that I think Rotary is now beginning to focus on as a highlight in Rotarian President Mehta's term. But it's also starting early. So if she has the opportunity to go to school, she's more likely to, in the long run, have safer births, fewer children, and have a better voice. She's also able to have alternatives to motherhood. In other words, she can work at the community, she can start a business, she can join community leadership, she can work outside her community. And that gives her both status and the ability to make those decisions and those decisions respected. We found that even women who migrate from Mexico for like picking crops, when they come back, when they have money in their pocket, they are respected in their communities. And so it doesn't necessarily start with education. It can start anytime when people are recognizing that women's contribution to smart ideas, smart investments, and the way they use money is also usually better for the family than the way men use their resources.
So speaking of resources and funding, why are so many healthcare facilities for mothers and children underfunded?
Well, I think I wanted to refer back to Dr. Mahmoud Fatallah's point that they just societies haven't felt that this was a priority. If you look at how much money goes into oncology work, or investments in prolonging life at the end of our years relative to maternal care, it's quite remarkable. And in terms of new investments in research, the same is true. Drugs for specific diseases, as opposed to kind of making sure that simple services are available to everybody. In the east side of Washington, D.C., there are no high quality maternity services. People have to go out of the city or out of their area. Some cross into Maryland, some go to Virginia. It's really quite remarkable, and it's historical in its origins. Where poverty exists, people fail to invest in the rights of women who need those services to survive and to allow their children to thrive.
And can you tell us what the difference is between health and well-being?
WHO talks about health as not simply the absence of disease. So when we think about health, even our medical specialties often focus on a particular organ system or a particular disease. WHO thinks about health as more than the absence of disease, but rather a sense of well-being. You're well-fed, you have choices, your care is available in lots of different places with different health systems. India has many different health systems, Ayurveda, among others. And when people have the ability to make the choices about what healthcare they receive, where they receive it, who they get it from, that isn't just health, that's a sense of well-being.
Okay. What does it mean to scale up for public impact?
One of the things that I've learned since joining Rotary that our district grants are $10,000 to $20,000 or something like that, and they're supposed to last a year. It's difficult to make big social change with $10,000. And if you want to make a big social change in people's lives, improving education or improving health care for women and children, you need to do it at a bigger scale. If you look at the numbers of maternal deaths around the world went from 300 to 100,000 live births. You have to go to a lot of places to find those women that are dying. You don't have to find places where the women are being treated poorly or aren't receiving the standard of care that we'd like. But in order to reduce the deaths, you have to get at big scale. You have to go to lots of places, lots of geographies to make sure that they meet the standard of care.
Got it. Okay.
That it doesn't mean that small projects or beginning with a small project like human milk banks doesn't have value. The milk banks, and Dr. Pallavi will talk about this, these are cases that are particular acute and need a specific type of care urgently. So if we do it enough places, if the milk banks, for example, get spread throughout India, I mean, that'd be terrific. It requires our thinking about what the end game is. If the end game is to improve services at a single facility, we aren't having a public health impact.
Okay, I think we're probably ready to move on then, Bob.
Those are great questions, Marlene. Thank you very much. And thank you, Bob.
Yeah, thanks, Marlene. And thank you, John, for those great answers. Did you want to highlight the guidelines that you had sent to us earlier? We had John's a rich source of information, and you had given us something about.
Well, WHO just published this week new guidelines on postnatal care, where they say this is the best evidence-based work recommendations that we can provide, and in them they make reference to human milk banks, and so this is like breaking news that this club is getting a presentation from some of the premier places in the world about best practices, and so I shared that with Bob and Lou and Dr. Deshpande, and I think they'll send that around so you can put this into bigger context. this is part of a really good quality of care. And you'll see in the pictures that Dr. Deshpande has, that this is probably the best care you can get in India and maybe around the world.
Okay, thank you. Thanks, John, for those valuable insights into reproductive justice and healthcare delivery. Maybe more of our Rotarians will undertake and support projects to support women's health. It sounds like an important thing to do. And I really think that the people in this program, in your audience presently, they have that real sentiment. So we're going to shift to a second speaker, and John talked about Dr. Pallavi Deshpande, who will be coming up soon. She's going to tell us about some milk banks, but I'm very happy to tell you that, and I don't know that they're necessarily named in her presentation, but I'd like to recognize Ramesh Purandare, who's with us, and Deborah Geiger. These are primary contacts in the Pune Mothers Milk Bank that you're going to hear about. Also, the second milk bank that she'll talk to us about has been supported by our friends in District 7450 in the Media and the Central Chester clubs. But having said that, let's welcome Dr. Pallavi Deshpande, who will tell us about Mothers Milk Banks. Dr. Pallavi.
Thank you, DG Bob. Good evening to all dear Rotarians from the districts of 7430 and 7450. First of all, I would like to thank DG Bob for giving me an opportunity to talk on this very important topic of human milk banks in India at this special meeting. I would like to acknowledge the presence of the Rotarians who have worked on the milk bank at Pune, which was one of the first milk banks set up by Rotary in India. Rotarian Ramesh Purandare from District 3131 and Rotarian Deborah Geiger. It's very nice to see you all here. I also would like to acknowledge the presence of the primary international sponsor of our global grant to establish the Human Milk Bank, Rotarian Vasant Prabhu from the Rotary Club of Central Chester County from District 7450. And Rotarian Sanjay Deshpande, who has helped us connect and work on this project over the last 1 year. So, the next slide. Can I share it, Rotarian Lou?
Are you not sharing that?
No, I think Lou has started sharing it. So
Yeah, I'm sharing it.
can I try sharing the screen?
Sure.
Yeah, Lou, I think
Yeah,
she's got.
I have to stop. Go.
Thank you.
Go ahead, Dr. Pallavi.
I just changed the slide. Are you able to see it?
We are, yes.
Thank you. So over the next 15 minutes or so, I will be talking about the need and concept of human milk banks, the current scenario in India. I'll give you a brief outline about the human milk banks that Rotary has worked with at Pune and Harvard and the benefit and impact of human milk banks. So as we all know, nutrition is one of the most important factors of care for hospitalized infants, especially those that are born preterm. And in the preterm babies are those which are born earlier to 32 weeks of gestation. In the preterm babies and in the low birth weight babies, breast milk is said to be more than 10 times important than in the normal newborns. And WHO states that the best food for the infant is mother's own milk. We know the benefits of breast milk over artificial formula in both healthy as well as sick children. And when mother's milk is not available, the next best choice recommended, especially for vulnerable babies, such as very low birth weight preterm infants, is pasteurized human donor milk from selected healthy donors. So research shows that out of the 6.6 million under 5 child deaths, more than 44% occurs in the first 28 days of life, which is a neonatal period. And India has the highest number of preterm births in the world. And due to many factors such as poor maternal nutrition or some beliefs or societal stigma, breastfeeding rates are suboptimal, especially in the first few months of life. India also has has a very high neonatal mortality rate of around 22 per 1,000 live births, when compared to those of developed countries, which is around 4 per 1,000 live births. India contributes to 1/5 of the global live births and more than a quarter of neonatal deaths. So breast milk is very important for preterm babies, those who are born less than 32 weeks of gestation, and for low birth weight babies. A baby is considered as low birth weight when at birth the weight is less than 2.5 kgs. And breast milk is proven to be protective, where babies show better survival and a decreased rate of infection when they are fed with breast milk. This particular group of babies are most vulnerable. And in the initial phases, the mothers may not be able to produce sufficient milk to meet the needs of the baby. And in this scenario, human milk banks fill in the void and supply breast milk to these vulnerable infants till the mother's own supply comes in. This slide shows the definite advantages of breast milk over formula milk. As we all know, breast milk is loaded with nutrition. It has the right amount and the right quality of proteins and other nutrients which are required for the growth of the brain and other organs of newborns. It has species-specific ingredients promoting brain growth and cognition. It also has immunological factors such as antibodies, which help protect the baby from infections, especially in the first 6 months of life. And the most important advantage of breast milk is that it is free of cost. The mother can feed her baby anytime at any place. Formula milk is an alternative. It has supplemented vitamins and minerals. It has the advantage that it can be fed by other guardians. However, it is expensive, especially in a developing country like India, where we have a large number of mothers from the rural areas or from the lower socioeconomic strata. And if it is not prepared in the right manner with sterile precautions, it can cause infections to the babies. So human milk banks are centers where milk is collected from healthy donors who have excess human milk. These mothers are screened for infections before milk is collected from them. The collected milk is then processed. It is pasteurized to make it sterile. It is then frozen and then dispensed by prescription from a doctor to recipients who are not biologically related to the donor. It is, as we all know, it is the safest and healthiest source of important nutrients for the baby. And it offers solutions to the most vulnerable babies in society, that is the premature and growth restricted babies being cared for in the NICUs. So the first human milk bank that was established in the world was in the year 1910 in Boston, USA. However, in India, it was first established in 1989 in Mumbai, in a place called Dharavi, in Sion Hospital. And it has gathered momentum only over the last 5 to 6 years in India. Currently, we have about 80 operational milk banks in India, which are working based on the national guidelines on lactation management centers. And most of these milk banks are concentrated in the western and southern parts of India. Most of these have been established in government sectors, and few which are established in the private sector cater to their own patients. It's heartening to know that around 20 to 25 of these human milk banks have been established with the help of Rotary. And this, the picture, the lower picture is the inauguration of a milk bank in the northeastern state of Assam, where about 2 years back, 10 human milk banks were established. And that's a really great contribution by Rotary. These milk banks, which are established by Rotary, are sustained due to contribution by the hospitals. Some of these are supported by the National Rural Health Mission of India, which is now very actively encouraging the establishment of milk banks. And a few of these milk banks are managed by private donors. So the first human milk bank that I will be talking about is the Yashoda Human Milk Bank at Pune, which was established at Sahyadri Hospital, Pune. It was conceived and implemented by the Rotary Club of Pune Pride. I'm sorry, there's a slight spelling mistake. It's Rotary Club of Pune Pride from District 3131. Project contact is Rotarian Ramesh Purandare, along with the Rotary Club of Bethlehem from your home district of Rotary district of 7430. And Rotarian Deborah Geiger has been an important part of this project. This project was executed under Global Grant number 1415627. And the facility started operation on 17th August of 2014. So it has been almost 8 years now since the milk bank has been working successfully. So just to give a background of how this milk bank was established, the Rotarians from the Rotary Club of Pune Pride had many discussions with doctors from KEM Hospital Pune, and there were concerns about the rising neonatal mortality rates. So they had a discussion and decided that probably the solution would be to establish a human milk bank. And after it was conceptualized, since the available space was not there at KEM Hospital, the same group of doctors were working in Sahyadri Hospital, Pune, which was an upcoming new hospital. And so then it was decided to set it up there. After the setup, in the initial 1 or 2 years, they did not see much of a response. So the Rotarians then very actively and routinely conducted awareness programs for doctors, for mothers of newborns. They counseled them, they motivated them to donate, and there has been no looking back since then. They've done wonderfully since the last 5 years and helped a lot of babies in and around Pune. And these are some brochures of training programs that they have conducted over the last few years. So this is the success story of the Pune, the milk bank, which is working very well at Pune. For the last 7 years, the amount of raw human milk that has been collected from healthy donors is around 785,000 milliliters. The volume of pasteurized human milk, which has been dispensed to the NICUs or maternity wards, is 648,000 milliliters. And the most heartening figure from this table is the number of babies that have received pasteurized human milk over the last 7 years, which is around 2,678. It's very satisfying to see this number, and it shows the success of the human milk bank. I would also like to highlight that around 30 Rotarians from different clubs in Pune are engaged in promoting the human milk bank for collection of raw human milk and for utilization of the pasteurized milk at various hospitals and NICUs in Pune. So these are a few pictures of the human milk bank at Pune. It is now running successfully. It is also very well connected to hospitals around to collect the milk as well as to provide the pasteurized human milk to newborns. And this was an inspiration for the next milk bank that is coming up at Dharwad in South India in my city. It was also a proud moment when a small snippet of this human milk bank at Pune, the Yashoda Human Milk Bank, was featured in the Rotarian magazine in the month of November 2014. It just shows that it was such an important project that was required in that area. So the Human Milk Bank at Dharwad is an upcoming project, and it is a recently approved global grant of our district 3170. This was conceived and implemented by our club, which is the Rotary Club of Seven Hills, Dharwad, along with the Rotary Club of Central Chester County from Rotary District 7450. At this point, I would like to thank Rotarian Vasant Prabhu from who is our primary international sponsor for having supported our project all along. I also would like to acknowledge Rotarian Sanjay Deshpande who helped us connect with different districts in USA and get contributions. I'm especially grateful to the clubs and districts of 7780 and 7870 and to PDG Carolyn, who have contributed immensely to this project. So this will be executed under the Global Grant 2232-708 shortly. So basically our Rotary Club conducts activities every year in the breastfeeding week, which is the first week of August. We routinely conduct awareness programs and health camps for mothers and children. And during one such activity about 2 years back, we had a discussion with the pediatricians who were there about the need to find a solution to the high number of infant deaths, especially preterm babies in our district. So we discussed with the local health authorities, and then the concept of a human milk bank was put forth. So we started exploring and then contacted the Rotarians from Pune. We were inspired by their project and then worked under their guidance to develop our project at Harvard. We had multiple meetings and discussions with the team from SDM Medical College, which is a tertiary care center in Harvard, and then also presented and had meetings with international sponsors from USA. So finally, with the efforts of all the Rotarians, global grant worth $77,000 was finally approved on 11 January 2022. So the beneficiary hospital where we are going to be establishing the human milk bank is a tertiary care center in our hospital, which caters to more than 10 districts of North Karnataka state and sees around 4 lakh outpatients and 45,000 inpatients per year. This hospital has a very good set of laboratories, and it has 50 NICU beds, and around 250 babies have access to treatment at the NICU per month, out of which around 75 babies are preterm babies. And the NICU is currently being expanded to maybe around 75 beds, which will be established shortly. These are a few pictures of the NICU at SDM Hospital, Harvard. They have different sections for babies who are born outside the hospital and are referred here, and for babies who are born within the hospital. They also have different sections for phototherapy, where you can see babies being treated in this NICU. So this project is proposed to start working in the month of May 2022, and it will immensely help the newborns, neonates, and infants of our region, especially the vulnerable group of preterm babies and growth-restricted babies. It will also support mothers who are not able to feed their babies with breast milk, who have medical conditions or complications from childbirth. We estimate, based on the data from the Pune Milk Bank, we estimate that the number of babies who will be benefited from our project will be around 300 to 400 babies per year. And this was one small incident which I wanted to share. As we were working on developing this human milk bank project last year, in the month of May, India was undergoing a very deadly COVID second wave. And we saw these messages coming up on social media where mothers who had just delivered had died due to COVID, and their babies did not have any milk. And it just shows the importance of a human milk bank in every area, and which can really make a difference to newborns. So a human milk bank definitely offers families a chance to provide their child with reliable and healthy milk from other mothers. It will contribute significantly to a reduced neonatal and infant mortality rate in that region. It will also help in providing optimum nutrition for all babies and reduce the use of formula milk in NICUs. Just a few pictures of successful human milk banks in India. This is the Yashoda Milk Bank, which has been established at Pune. This is a milk bank which is at Belagavi, which is about 100 kilometers away from our city. It is in a private hospital. We have another milk bank in Pune established at the D.Y. Patil Hospital. And these are the two milk banks which have been established with the help of Rotary recently. One is the Rotary Amrut Human Milk Bank at Mangalore, which was inaugurated in the month of March, and Adya Rotary Human Milk Bank at Bangalore, which was inaugurated in the month of February. Thank you so much. I'll be very happy to take any questions.
Thank you. Does anyone have a question for Dr. Pallavi? Marlene, is there anything in, oh, I see a hand. Melissa Kirk, you have a question?
I do. So, can you hear me? I just turned on my microphone. Okay. So I have a technical question. So you say that the milk is frozen. Is that just regular frozen, or is it a deep freeze like a -80 or a liquid nitrogen?
Yeah, it's a deep freezer at -20.
So does that make difficulty in storage, like increase costs in storage and transportation?
No.
No problem with that.
Because the idea is that the milk will be stored at -20. It can be stored up to 6 months.
Okay. 6 months. All right. And then do you have trouble recruiting donors, and do you pay your donors?
We've no experience right now, but from what I've heard from the other milk banks, initially it does take some time to get donors to come and donate. We have to repeatedly go into the postnatal wards where mothers have just delivered newborns, counsel them, educate them, create awareness, not only for mothers, also for pediatricians, doctors, and healthcare workers, because when they keep motivating people and creating awareness, it sort of increases the willingness to donate. And no, we don't give money to donors. I mean, none of the milk banks in India do that. We encourage them to donate. It's basically like, this is what is the experience of milk banks which are working for the last few years, that they believe that it's a selfless act by one mother to save the life of another mother's baby who does not have enough milk of her own.
That's
So
wonderful.
yeah, so and that is what the mothers who have donated excess milk have also said. And some of them even overstay their hospital stay just to donate their milk and help newborns.
That's wonderful. It's a great program.
If I can add to that, these mother donors are felicitated at different occasions. Okay, and so that's why they get the motivation out of it.
Marlene, I think I saw a question in the chat box.
First, Dr. Sanjay Deshpande.
Oh, Sanjay has something? Go ahead.
Yeah, hi, Pallavi, you said that the donated milk is not given to a baby that is biologically related to the donor. How far does that biological relationship go?
No, the concept of a human milk bank is to give milk, pasteurized human milk, to recipients who are not biologically related to donor. Because if the mother is able to express milk, then definitely she can give it to her own baby. She can feed her own baby.
Correct.
So it is mainly for recipients whose mothers cannot produce enough milk, and therefore the milk has to be given from another donor who is not biologically related.
Okay, but if the baby is a niece or nephew of a lactating mother, is that allowed?
Yeah, that's allowed. That's allowed.
Okay.
Okay, and we did have a question in the chat. Does the pasteurization take out antibodies and or other nutrients?
No, pasteurization has been found to retain all the macronutrients that are present in human milk. It does not also affect any of the bioactive immunological factors in human milk. So it does not disturb any of the nutritional value of human milk. It just makes it sterile.
Okay, that makes sense. Any other questions in the audience?
Marlene, do you have any questions?
I have one here. Why is it that some mothers are not able to produce enough milk?
Yeah, so lactation failure occurs due to both physiological and pathological conditions. So it could be the stress of delivery, and there may be some other pathological conditions like breast abscess or any other complications during childbirth, which may not trigger the production of milk. And especially with when a mother has given birth to preterm babies, the stress, discomfort, and fatigue does delays the milk production, especially in the initial first few days of life. So plus some mothers genetically are not do not produce milk.
What is the typical time that it takes for a mother's milk to come in?
It should be around 24 to 48 hours. Initially, the mother produces a thick milk, which is known as colostrum. And then later, after 24 to 48 hours, she's able to produce the milk, human milk.
What is the deficit to the child of not getting the colostrum?
Colostrum is very good because it is loaded with antibodies and other nutrients which are required for the, it's also loaded with sort of like it's energy for the baby. But if it is not available, then the alternate would be to give either pasteurized human milk or formula milk to babies. Because babies go into hypoglycemia very quickly. So we cannot wait for the mother to produce milk. We have to feed the baby with another alternative.
We have another question in the chat. Do donor moms pump and take milk to the collection site or go to the collection site and pump there?
Most human milk banks prefer that the mothers come to the center and donate because that is where they are counseled, their consent is taken. They are sort of trained how to collect the milk. They have to clean the area, maintain hygiene, and then express the milk in hygienic manner in sterilized collection bottles, and then that is then stored, pasteurized and stored. But a few milk banks I've heard in Bangalore also offer the option of collecting the milk at home. So in these cases, the sterile kit is transported to their house. So the mothers can avail of this facility like by an online appointment, and at that particular time they are provided with the kit to collect milk, and then that is transported back to the public milk bank.
So you couldn't just take, like say your child was suddenly weaned and you find that you have 6 bottles left in your freezer, you couldn't just take those and donate them?
You could, provided that it has been collected recently. And that milk bank, it depends on the policy of that human milk bank. If they are open to accepting milk from donors who have already collected outside, then they can accept it.
Okay. That's it for the questions that I have. Oh, how do mothers' milk banks created through Rotary Global grants become sustainable?
So sustainability, I believe, is like a collective effort. So it involves efforts from Rotarians, from the local health authorities, from the beneficiary institute, from NGOs who can be cooperating to create awareness and publicity about the donation of human milk. So collectively, we can motivate mothers of newborns to donate their excess milk instead of just expressing and wasting it out. We can also create awareness about the importance of breastfeeding infants and how it makes a difference to the neonatal mortality. And definitely global grants also provide funding to establish state-of-art human milk banks. So Rotary can definitely make a difference in establishing human milk banks and making it sustainable.
For hospitals and families, the fact that you don't have to pay for commercial formulas is a major saving, economic saving.
Yeah.
And in addition, I think what Dr. Deshpande said, there's a growing group of evidence that when you form breastfeeding supportive communities, that the more women are likely to come in and provide that support, and it's sustainable over time. It becomes part of the natural health system, and I would say part of reproductive justice.
As we were coming on tonight, I caught a glimpse of a news report saying that supermarkets and stores are starting to restrict access to formula. They're limiting how much formula people can get. So it's even more important than ever that women be able to use their own milk or milk banks. So if say somebody watching tonight says, this is something I need to get my club involved in, what's the next step?
So if they are interested to work with a club in India, then maybe they will have to explore maybe on Rotary Showcase if there's any club who has put up their project looking for partners, or contact people who have already established milk banks and find out if there are any more in pipeline.
Professor
our next-
Dolapo Lopedeju from our Nigeria office is on the line, and maybe he would say about what would work in Africa. But I think one of the important things that is here, as neonatal mortality goes down through better quality of care, the need for milk banks becomes more acute, because it isn't just for any woman or any child that's born in a facility. It's those who are preterm. You saw the pictures. These are kids who really need, particular care, and so the availability and use of human milk is a real boon to these low birth weight preterm infants that are less likely to survive if they don't have this care.
Deb, I saw your hand up.
Yes, thanks. Dr. Deshpande, thank you for your great presentation. When we were working with the Pune Club on developing the milk bank there, we started doing some research locally, and it was interesting. We found that in the state of Pennsylvania at that point in time, there was no milk bank, and there was some work to develop one going on by some folks over in on the Pittsburgh, on the western side of the state. But there was also a shortage of human milk in the Philadelphia area. CHOP, we had a club member whose son was injured and was down there. And during the time that his child was being cared for, he learned through the physicians and other healthcare professionals that they had a shortage of human milk. Because there was no human milk bank locally, they were having to go to other states to try to get some. So for a while, we had done some research, and we're thinking about trying to get a project going to develop one on the eastern side of the state. And that fell through for a number of different reasons. We just didn't have the time and people to put the effort into it, but that may still be needed. We had learned through our health department that there were informal networks over social media where women who could not produce milk were trying to find other women who would share their breast milk with them. That was not necessarily a very safe practice, but they felt that that was one way of improving, getting their child some immunities and different things. So it's a worldwide problem, but we have different reasons for needing it in our country than we do in other countries in the world.
Yes.
I volunteer in the NICU at LVHN, and there's a huge refrigerator there of mother's milk, but I'm sure it's just for their babies, and they do use formula there. So I was wondering about that. And any other questions? Anybody have?
I think it's just civil society groups like Rotary who raise their voices and say, hey, we'd like to have this, from a community perspective and from a public health perspective. We need this in our communities. And it's likely to happen when Rotary and other civil society groups get involved. Then you'll get the professional associations to join in. They'll say, yeah, this makes sense. The hospital administrators will say, yeah, we can save some money and improve lives. I think this is what Deborah Geiger has said is a really important thing, and using the example of India and elsewhere is really a great example of best practices, good science, and great community health.
Okay. Well, listen, I want to thank both of our speakers. Dr. Deshpande, thank you for your inspirational and technical insights into the importance of mother's milk banks. I hope that we in our districts locally will continue to support these projects in India and elsewhere. Please join us for the next Showcase Tuesday on the 14th of May about the Rotary theme youth service. Our speakers will be Sarah Stackhouse, who's gone through all of the youth programs that Rotary has to offer, and she'll tell us about RILA, Interact, Rotaract, Exchange, and she'll tell us about her current book. She's an author. We also have Carolyn Jordan from our West Reading Missing Club and longtime member of our District 7430 Youth Exchange Program. And she'll tell us about how we're going to gear up for in-person exchange in the coming years, starting July of this year. So listen, please have a good night, or if you're in India, have a great day.
Just before you close, DG Walter, I'm happy to be joining you here. I'm Dola Polufadeju from Nigeria. I've been invited by John Townsend. It's a very interesting topic, which we may be able to take up in our next projects. But do schedule a webinar on maternal health and family planning in Nigeria and Sub-Saharan Africa, and I will be glad to shed some insight into that topic. Thank you very much for the invitation.
Thank you. Thanks for speaking. And please know that this has been recorded and will be available to you later. We're going to try to get this out to those who registered tonight. So please, as I said, have a good night or a great day. And thank you for coming out.
Thank you.
See you.
Thanks, Bob. Bye-bye.
Thank you.
Good night.
Thank you.
Thanks.
Bye.
Dr.
Good night.
Bye-bye.
Thank you, John.
Right.